Welcome, everyone. I'm Dick Deming. I'm Medical Director of Mercy One Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our guest this evening is CEO Shelley Fuld Nasso. She's the CEO of the National Coalition for Cancer Survivorship in the DC area. And welcome.
Thank you. I'm so happy to be here.
So Shelley has many accolades, including being a graduate of Rice University, and she holds a Master's of Public Policy from the Harvard Kennedy School. And she was sharing with me that she grew up in Texas. Mm-hmm. So tell us a little bit about yourself. How did you find the field of advocacy, and specifically advocacy in cancer-related issues? How did those two come together, and which came first?
Well, I'm a policy nerd at heart, a policy wonk, I like to call myself. And I got, as you mentioned, I got my master's degree in public policy. And I worked for a little while in the internet industry, worked for Yahoo and actually Match.com. But I knew that I really wanted to work in the nonprofit space and to try to use my public policy degree. So I lived in Dallas at the time, and I got a job with Susan G. Komen working on public policy issues. So I had some connections to breast cancer, some family and friends who had had breast cancer, but really it was a way to just use my public policy degree to try to help other people. And that was back in 2004. I started with Komen when I was pregnant with my son, who's now a college sophomore. So I worked for Komen for a number of years and did a lot of public policy work on both the federal and state levels. And then about 10 years ago, I had the opportunity to move to the Washington, D.C. area to become the CEO for the National Coalition for Cancer Survivorship. And what I love about that is that we at NCCS we advocate for everyone touched by cancer. So it's not like just breast cancer survivors or just lung cancer. And I think that there's so many incredible organizations that help people with cancer, but sometimes there gets to be a little bit of, infighting and, competition. And I just love that anyone touched by cancer from diagnosis onward and their family members are people that we advocate for. And we have a very strong focus on public policy, which is why we're based in the DC area, as you said. And I just love it because it combines things that are just important to me. Like I said, I'm a policy wonk, but I also, in that time since I started in this field, I've had many more people in my life touched by cancer. My best friend passed away about 11 years ago from kidney cancer. He was a doctor himself, and he was diagnosed with stage 4 cancer and lived for about 19 months after his diagnosis. And seeing his experience and seeing, the positives about how well the cancer care, about how we take care of people with cancer in this country were helpful to me. But I also saw some of the problems, that he didn't get palliative care. He didn't have hospice until the last week of his life. And even then it was too late. I mean, he should have had it longer. He should have had more support at the end of his life. And so I saw a lot of the ways we don't, that we fail patients, I think, that we could do better for patients. And it made me, just strengthen my resolve to want to work to try to make the cancer care system better for everyone.
Yeah, advocacy is so important. As a cancer doctor, I have the opportunity, one patient at a time, to help reduce the burden of cancer. But as a volunteer for an organization that goes and lobbies for public policy, if we have public policy success, we can affect millions of individuals. Mm-hmm. So it's wonderful for individuals to be able to be involved with both the clinical aspect, but then also use their expertise, and especially cancer survivors who tell their story to the legislators and can use their own personal story to help advocate for public policy change.
Yeah, my favorite part of my job is taking people to Capitol Hill who've never been to Capitol Hill before, never met with their legislative officials, and showing them that their voice matters. And I know you said you were on the Hill last week advocating for cancer patients, cancer survivors, but we host a Hill Day every year in June where we bring advocates from around the country and just teaching them how to tell their story in a, really succinct manner, because you don't have a lot of time, and how to sort of marry the data and the policy analysis with the story to try to make that case for why whatever the legislation is that you're talking about. And there's so many different ways that legislation can affect cancer survivors. It can be the funding that we have for research at the National Cancer Institute, or the Centers for Disease Control, or it's also how the Food and Drug Administration reviews drugs that they approve for cancer patients to treat their different types of cancer, and then how we pay for cancer, like how you get paid as a doctor. Medicare is probably your biggest payer, because most people with cancer, or half of people with cancer, are Medicare beneficiaries, roughly. And so how Medicare pays for cancer care affects how cancer care is delivered. So there's all these different ways that patients' voices have to be included in the discussion about the policies that affect the kind of care that you get, the kind of research that's done, the kind of drugs that are approved, and then just the way you get your care. So there's so many ways to weigh in. And what I love to do is teach people how to use their voice, and then bring people who have the stories to tell to the policymakers, so that they can hear from the people who are impacted by their decisions.
Yes, because there are lots of decisions that get made every day
Mm-hmm.
in Washington, D.C., and in our state capitals that
Yeah.
affect patients significantly. Let's talk a little bit about what you see as some of the issues. So when I see, I have a cancer survivorship clinic. So when I meet a patient for the first time that, let's say in this situation, we're talking about patients that have already been through cancer treatment and
Mm-hmm.
are at the present time cancer free, I will often say, tell me, what are some of the lingering issues? And by lingering issues, I mean physical, psychosocial, emotional, financial, spiritual, philosophical. What are some of the issues you're experiencing as a consequence of your cancer diagnosis or your cancer treatment? And what would you say are some of those issues that you see are kind of ripe for public policy and advocacy?
Well, so two things I want to talk about. So one is, we do a survey every year called our State of Cancer Survivorship Survey. And this is our 5th year to do the survey, and that we're actually sharing the results of the survey at a webinar next week, October 3rd. And if you go to our website, canceradvocacy.org, you can sign up for the webinar and listen to the survey results. But we survey cancer survivors across the country, a variety of different, and all different types of cancer, all different ages, parts of the country, types of cancer, race and ethnicity. And we ask, what are the issues that you deal with during treatment and after treatment, and how satisfied are you with your cancer care? For the most part, people are pretty happy with the care they get, because they're grateful to be alive, even when they're talking about things that maybe aren't the best about their care, like gaps in their care, or feeling like their care is not very coordinated. Or sometimes, we just hear from people that they feel lost after they finish treatment, and they've sort of transitioned to this post-treatment, but not everybody has the kind of support that you're talking about, because oncologists are busy. They have a lot of cancer patients that they're treating, and they don't have as much time for people who are post-treatment, especially as more and more people are diagnosed with cancer. Primary care physicians have a lot on their plates. They're trying to manage all different types of, chronic conditions, and they don't necessarily have the time to learn about all the different potential long-term side effects of somebody who's had this type of treatment. And we don't do the best job of communicating that sort of end of cancer treatment and transition to post-treatment survivorship. We've advocated for a long time that patients should have a care plan that helps them at the beginning when they're diagnosed with cancer, when they make any changes in their treatment throughout their course of treatment, and then when they make that transition to post-treatment survivorship, that really outlines, especially in their survivorship care plan, here's the treatment that you've had, here are the potential side effects that may happen later, here are the things you need to do to kind of reduce your risk of recurrence, to manage your health, to have the appropriate surveillance or screenings for a recurrence of cancer or secondary cancers, and really help them. We hear from survivors that they struggle with things like, what should their nutrition be? They know that exercise is important, and it's especially important for cancer patients, cancer survivors, reducing the risk of recurrence, but they don't necessarily know what to do. And I know you address that. in with the patients that you serve, but not everybody gets that information. And so we really think this survivorship care plan would be a really important way to help communicate that, help the patient understand what they need to do, help communicate with primary care, and so that everybody's in the loop and knows what needs to be done. And it just doesn't always happen. And part of that is because it's not adequately reimbursed. And also people don't always think it's as important. So one of the things that we've advocated for is reimbursement for that cancer care planning, so that physicians get paid to do it, or to have their nurse practitioner do it. And we think that that will help improve that coordination of care and help the patient feel a little bit less lost in transition, and from kind of the treatment to the post-treatment phase.
And you're right. Cancer doctors tend to prioritize killing cancer cells
Right.
as their number one goal. And they are, in general, have enough patients under treatment that remains their primary goal. And even though everyone would sign a letter saying they agreed with everything you said, when it comes down to what do you actually do in your practice and how do you take care of those patients, how do you provide them treatment summaries and care plans and programming, it just doesn't happen. And
Mhm.
I'm interested, and obviously you can't spill the beans on what you're going to tell us on October 3rd, but you do this survey annually. Can you give us a little bit more insight into the surveys in the past years and what has risen to the top of
Mhm.
concerns that cancer patients and cancer survivors have about their treatment or their post-treatment care?
Yeah, sure. I can give you some themes that we've seen over the years and also some previews of what we're going to be sharing next week. So patients, as I mentioned, are very satisfied with their care because they're really just grateful to be alive. They're grateful to the healthcare team that helped them through their treatment. And even though the treatment may have been really difficult, there may have been challenges, it may not have been well coordinated, they're just grateful to be alive. But when we ask about how satisfied are they with their post-treatment care, it's much less. I mean, well, it's about 10 points less satisfied with they're still relatively satisfied, but it's not nearly as satisfied as they are with their treatment itself. They don't always feel like they understand what to expect in the survivorship, the post-treatment survivorship. We ask about who manages your care, and it's kind of split between oncologists and primary care physicians. And then we ask, what are you talking about in those post-treatment visits? And the overwhelming focus of the post-treatment visits is on the scans or the tests to see if there's been any, recurrence. It's not on the quality of life, the exercise, the nutrition, the long-term side effects that may be really challenging for them. So they're telling us that they have these long-term side effects.
Mhm.
They're telling us that the healthcare team isn't very helpful in addressing them, but they're not talking about them in those appointments, those post-treatment appointments. And then we ask, what do you wish you were, or what would you like to be talking about? They're pretty focused on the scans, and we hear people talk about scanxiety, that nervousness about the scans, and is the cancer going to come back or is it going to progress? And that seems to have sort of overtaken those visits. And so they're not like what you said, where you ask, how is the cancer affecting their lives? It's affecting their sleep, their mental health, they have sexual issues is one that's very high, but not very, they don't find the healthcare team to be very helpful in dealing with that. But yet they're not talking about it. So we've got to find a better way to make sure that we're eliciting that from them. And it sounds like the way you talk to your patients is really asking them kind of what are the challenges you're still dealing with as a consequence of your cancer treatment. But it doesn't, from what we're hearing from people, it doesn't seem to be happening as well.
Yes. And as you mentioned, it's almost a bit of a conspiracy between the patient and the doctor.
Yeah.
They both are focused, especially in the very early years. Has my cancer come back? Am I still cancer free? So that is the number one concern of the doc and the patient. And
Mhm.
then there is also this sort of conspiracy of silence about issues like sexual function, where
Mhm.
The doctor doesn't bring it up, so the patient doesn't know that they should bring it up. The patient doesn't bring it up, so the doctor goes, "Well, I guess we don't have to go into that
Yeah.
arena." And so it just doesn't get talked about because nobody wants to be the first one to bring it up. And as you mentioned, in order to address patients' needs, you really need to do it systematically with every
Mhm.
patient. Go down what are some of the physical issues you're experiencing, and as you also alluded to, some of the side effects of cancer treatment can happen years
Yeah.
after the cancer treatment. Some of the delayed effects, I'm a radiation oncologist, and some of the
Mhm.
side effects of radiation to the pelvis or to the breast may not really be evident, or to the throat, the head and neck region
Mhm.
might not be evident until years later. And at that point in time, they may no longer be seeing the radiation oncologist. So how do we systematically provide patients with this understanding that we want to talk about the lingering, ongoing physical issues, but then
Mhm.
also be open to talking about the psychosocial, the
Yeah.
financial
Right.
toxicity that many patients, even with good insurance,
Right.
have suffered, along with spiritual and philosophical issues. So it does take a systematic approach, and it's not something that can be done in a 5-minute visit where
No.
you show the normal CAT scan and go on to the next patient.
Right. And our healthcare system is so fragmented that you get, go to this doctor for this, or this doctor for this, or this doctor for this side effect. And there's not, one person who can really help you address kind of all of the issues and help coordinate all that care. We don't coordinate care well. I mean, people will say their care is coordinated, but really patients are the ones doing it. For the most part, a lot of times all your doctors are not in the same healthcare system or on the same electronic health records. They don't know what the other has done. The communication is not good. And so it falls on the patient to be the one coordinating all of that. I mean, I've seen patients show me their binder that they carry around, and that they talk about how, how much of a huge time commitment it is to really manage all of that, all of the, long-term side effects, even after they're done with their treatment.
Yes, it is. It could be so much better. It's certainly, it shouldn't rely on the patient. I mean, the
Mhm.
patient goes from medical oncologist to radiation oncologist. It shouldn't be the patient's job to be the communicator between the two.
Right.
That should fall on the healthcare workers' responsibility. And someday, we'll have one unified medical record that'll talk to everybody, and it will help bring that together. But it doesn't exist. Even in my own cancer center, we've got
Mhm.
5 different electronic medical
Mhm.
records, depending on which practice the physician is in. You mentioned something that I wanted to touch on, because there is some Medicare um, regulation coming out around providing some compensation for navigation.
Yeah.
And so we might use the word navigation or coordination.
Mhm.
It certainly relies on a patient, but many health systems, including ours, a cancer center, has positions of nurse navigators that serve to function as real navigators to get a patient from one doctor's office to another doctor's office by
Mhm.
physically navigating them, but also being a resource for all of the other resources that are out there, being
Right.
the person who can bring on those resources when necessary. Are you involved in any of the uh, um, public policy advocacy
Mhm.
for things like compensation for navigation as an important core concept of providing that holistic cancer care with all of the support services?
Yes, definitely. So, first of all, I would love to have a system that's not so hard to navigate that we need navigators. But since we don't have that, people do need navigation. They need help navigating the system. And it's part of it is, like you said, just getting from one doctor to another or figuring out all the appointments you have to have. But also, all the different services or resources in the community that can be useful to you. A lot of times people just get handed a list of, things, places to call if they need financial help, as opposed to having somebody who knows, like, this is one opportunity to get, assistance with paying for a prescription drug, or this organization helps with, rent and utilities if somebody can't afford that while they're going through treatment. And so we need, one of the issues we have is navigation is sort of this very generic term, and it can mean a lot of different things. There are people who are financial navigators that help like with all of the insurance and reimbursement and all of the, figuring out how you pay for care. There's nurse navigators that help more with a lot of the clinical questions that can really provide more context around, some of the clinical issues. There's lay navigators that help people who, maybe if someone is Spanish speaking, they may need a lay navigator that really has that trust of the community, that can help translation and things like that. So there's sort of all these different kinds of navigation, and we haven't done the best job of defining who does what or what kinds of qualifications you should have for them. And I think we're working towards that. One of the things, so like I mentioned before, there's so many different ways to kind of approach public policy and to weigh in from a patient perspective. One of the things that we do is we kind of monitor all these regulations that are coming out, that the federal government will put things out to solicit comments from the public. And you were mentioning that this was the physician fee schedule that was put out this summer. And we submitted comments both as NCCS and then also with a group of other organizations commenting on that, asking some questions, giving some patient perspective on, why this is important. But here are some of the things you need to be more clear about if you're going to do this so that patients really understand and to make this work because it was not as clear as it could be to help people actually, make this happen. And because clinicians and cancer centers and hospitals are not going to do this unless they understand what they have to do to get paid for it. And so there were still some lingering questions about that. So we submitted comments on that. But the other way that we've been working on this is we have been working to support the Comprehensive Cancer Survivorship Act. And it was introduced in June by 5 members of Congress. Debbie Wasserman Schultz in the House is the lead on it, along with she's a Democrat. Representative Brian Fitzpatrick is a Republican, and Congressman Mark DeSaulnier, who's a cancer survivor from California. And then in the Senate, Senator Amy Klobuchar and Senator Ben Cardin have been working on this bill. They introduced it last December. It had to be reintroduced this year because every 2 years there's a new session of Congress. And if a bill hasn't passed in the previous session, it has to be reintroduced. So it's led by cancer survivors. They've worked with a lot of different cancer advocacy groups to get input on what should be included. And it includes some provisions for patient navigation as well. So, that's a lot of times you have to kind of work on things from more than one angle. You work on it with the legislation, but it's really, I don't know if you're following what's going on in DC, but it's very hard to get things done in Congress right now. I know this is going to be up on the internet, and by the time people watch this, we'll be well past it, but it's a very good chance we're going to have a government shutdown starting this weekend. So it's really hard to get Congress to do things. So if you can get Medicare to do things without going through Congress, and again, how we pay for care really influences what you receive as a cancer patient. So that's where we try to bring that patient perspective. Now the doctors are weighing in and cancer centers and hospitals and because they have a stake in it too, but we want to make sure the patient voice is heard as well. And so that's why we submit comments. We meet with the people at CMS, which manages the Medicare program, share the patient perspective on that. So it's, for a policy nerd like me, there's just a lot of ways that you can try to make sure that patients' voices are represented.
So let's talk a little bit about what policy nerds do, and I know it's relatively simple to think about when a bill has already come together and they just get ready to vote up or down, that you can, try to influence the vote to be one way or the other. But there's a whole lot of stuff that happens in the writing of the bill and in the regulations. Maybe if you can think of a particular issue that you could walk us through, and I know sometimes it takes years, where you came out with a win, but give us a sense for, as a professional advocate, how you worked an issue that eventually resulted in a piece of legislation that had a positive impact on cancer patients or survivors.
Sure. So there's two examples I want to talk about. Even this cancer survivorship bill that I was mentioning. We have been talking with Congresswoman Wasserman Schultz about this for probably 5 years. She's a cancer survivor herself. She was diagnosed as a young adult. She was just about 40 when she was diagnosed. She went through all of her cancer treatment and reconstruction. She had the BRCA gene, so she had to have prophylactic surgeries as well. Went through all this treatment and really didn't tell anybody, just a few close friends. Continued working through in Congress, doing her job while she was going through all this treatment. And then when she was done, she introduced a bill that was called the Early Act. So, and back at the time I was working for Susan G. Komen, and we worked with her on it. And it was really to try to help educate and support young women diagnosed with breast cancer, because more and more people were being diagnosed at younger ages. Also, people didn't necessarily understand the risk of genetic predispositions to cancer with the BRCA gene. She had it and didn't have any idea that as an Ashkenazi Jewish woman, she had a higher chance of having this genetic mutation. So we worked with her on developing what was in the legislation. Then once they introduce it, you work with them to try to get support for it. So you try to talk to all your different members of Congress to try to get them to sign on as co-sponsors. Then, as I mentioned, it's hard to get a bill passed on its own because especially when Congress isn't working when it's very dysfunctional. But one thing you can do if you have the right champion who's really committed to the cause is if they can attach it to a bill that's sort of a must pass bill. So a lot of times the spending bills are must pass, or there may be other bills that have to pass because there's some kind of deadline, and they throw in a lot of other things. And sometimes they're not necessarily the best things that they throw in, but if they're throwing in something that's going to help cancer patients, then we think that's a good thing. And so in this case, she was able to get that attached to the Affordable Care Act, which passed, again, this passed in 2010. So it became part of the Affordable Care Act. So she had a long history of working on cancer issues and using her own experience to try to help other people. So years later, she said she knew she wanted to do something on survivorship. So she spent a long time talking with us, talking with others in the cancer community. What's important to cancer survivors? Where are the gaps? What can we do from a policy perspective to help? So we really had the opportunity to work with her staff and help shape what was in the bill. And so that was very exciting just to help, be part of it. Because sometimes, members of Congress get their ideas of what to do from a lot of times from their constituents and from groups that, come and talk to them and that they see as experts in the field. So we worked with them on what to include in it. And then again, because it's hard to pass something, you sometimes pull out pieces of it that you get attached to a must pass bill, or that sometimes they can what they're going through right now, trying to pass appropriations bills to fund the government, this government spending. Sometimes they can include what they call report language, and they can include some of those pieces in report language. So there's sort of other ways of getting pieces of your bill enacted, or at least get progress on them without having the bill passed. And really, I think, I can't be certain, but I do think that all of this sort of advocacy around navigation is part of why Medicare included the navigation provisions that you mentioned.
Mm-hmm.
Another
Right.
example I mentioned, though, is back in 2017, the Affordable Care Act, when that was when they were trying to repeal it. And I know it was very contentious when it passed. A lot of people were not for it. But by the time they were trying to repeal it 7 years later, a lot of people were benefiting from it, including
Yes.
a lot of cancer survivors. And
At that point, it was, someone was elected to repeal it, and we had a Republican House, a Republican Senate, a Republican president, and it still didn't get repealed because by now people realized how valuable it was.
Yeah, because they didn't have a good replacement for it. They talked about repealing it and replacing it with something else, but they didn't really have that plan
Mhm.
to replace it. And by then, millions of people had insurance that didn't have it before. Cancer survivors who couldn't get insurance before because they had a pre-existing condition now had the ability. They weren't stuck in one job. they could move to another job, or they could do some work where maybe they wanted to do like freelance work. And before the Affordable Care Act, you really couldn't do that. If you needed insurance, you had to keep insurance. You couldn't have a break in coverage, or your employer could deny you. And once we had those protections for people with pre-existing conditions, it freed people up in their lives to do other things. They could choose to work part-time, or work, become a consultant, where they maybe didn't work for a company anymore, but they could go buy insurance on these exchanges. They couldn't be denied because of their cancer history. If they had treatment that they needed as a result of their cancer, if they were diagnosed with cancer, they would be covered for their treatment. And we just had to mobilize people to let their members of Congress know, we can't take that away. That's too important for people with any kind of pre-existing condition, cancer, and many others. So it was, millions of people really advocating with their legislators as to why this is really important. And it was a busy time, but a really exciting time to help people, cancer survivors, share their story as to why this is helping. This has helped me and others like me, and why we still need this.
Yes, I would say, and access to care is a huge issue. You can
Mhm.
come up with another $200,000 pill, but if n- people don't have access to it, it doesn't do a lot of good. So access to care is kind of one of the fundamental issues that
Mhm.
we spend a lot of time on. I would say the Affordable Care Act is probably the most important piece of legislation in my adult lifetime to provide access for care. You can go back to maybe the Medicare, the establishment of Medicare. The
Mhm.
other second issue that I'd like to talk about a little bit is Medicaid expansion, which actually was part and parcel of the
Mhm.
Affordable Care Act, but then had a life of its own as each state
Yeah.
got to decide whether or not they were going to expand Medicaid, and the role that Medicaid expansion has played in expanding access to care, and perhaps maybe talk a bit about the experience you've had in advocating in individual states.
Mhm.
Certainly, I have some experience in advocating here in Iowa, where we did expand Medicaid.
Mhm.
What's been your experience around the issue of Medicaid expansion around the country, and the role you see it plays in helping provide access to care for patients for cancer care?
Yeah. Well, there's now we have a lot of evidence of how Medicaid expansion reduced, deaths from cancer, because people who would not have otherwise qualified for Medicaid, because before the Medicaid expansion, it was very restricted. It was very hard to qualify for Medicaid, and with Medicaid expansion, more people could get Medicaid, and people who wouldn't necessarily be able to afford insurance, to buy insurance on the marketplace, but could get Medicaid. And it's really had a significant impact on mortality, because of and there was it was sort of for researchers, it was an excellent sort of natural experiment, because you had states that expanded and states that didn't, and you could compare the death rates, and the death rates went down in states that expanded because people had access to care. I We work more on a national level than at the state level. I fear, unfortunately, because you mentioned I'm from Texas, and Texas has not expanded it, and I don't think there's a good chance that they will anytime soon. Unfortunately, it's continued to be such a sort of hot button issue in some of the states. It's still possible. I mean, there have been some states that have expanded even in recent years, but it's very challenging, and because and it's kind of shocking to me that a state wouldn't, because what it really is the federal government paying for a huge portion of of the cost of it. So they're basically turning down federal government money that other states are getting for their citizens, but they're turning it down for their own citizens that could help them to get health care and potentially survive cancer or other diseases. But I think the states that still haven't expanded are pretty dead set against expanding, and I don't think the chances are great that any of and I'm not following it as closely as some. So there may be one or
Right.
two states where there's still potential, and I don't know. I didn't follow it in Iowa. I don't know how they did it there.
Well,
Sounds like you were
we
involved
did
in it.
it with this sort of a waiver, so they could say they weren't really expanding it; they were doing it with a little bit of a twist. But I would say now that we've had it, we say yes, we did expand Medicaid, and there is hope. My home state of South Dakota passed it last year, so
Yes, right.
there is hope that some other states will be able to do this to bring more access to
Yeah.
care for their lower income citizens.
Hmm.
What are some of the pressing issues that you think we're facing? So, one, obviously, funding. So, um, anytime you come up with a bill, when I was up at Capitol Hill last week, we were advocating for three different things, and of course, they want to know what's the
How
CBO
much is it going to
score.
cost? Yeah.
How much is it going to cost? And right now, we're just trying to get a flat budget to keep the government open, and
Right.
then hopefully once that gets established, we can start having a conversation about priorities,
Yeah.
because the priorities of the country are what you are willing to put money toward.
Right.
And we know that expanding funding for research saves lives, and eventually it saves money. But in the short term, increasing the NIH budget is not going to happen this week. And
Mhm.
besides expanding the budget for NIH, NCI, CDC, cancer research, what do you think are some of the major issues that your organization will be focusing on when it comes to, advocacy with a big A and lobbying with a
Right.
big L?
Yeah. So really our focus, because there's so many issues, and we a lot of times what we'll do is maybe we'll support a piece of legislation, but what we try to do, because we're not a huge organization, we try to really target our lobbying efforts, and our focus is really on the Comprehensive Cancer Survivorship Act that I mentioned that Congresswoman Wasserman Schultz is leading, and then also another bill, the Cancer Care Planning and Communications Act, and that would create that reimbursement for care planning, including the survivorship care planning. And that's being led by Congressman Mark DeSaulnier. So those are the two things that we're looking at, or that we're focusing most of our efforts on in terms of lobbying. But as you said, the big issue is cost. We don't, and you mentioned CBO score. That's the Congressional Budget Office that basically does an analysis to say how much something's going to cost the federal government, and they don't. Sometimes you can be advocating for something and they haven't scored it yet, so we don't know exactly how much it's going to cost. Um, Cancer is a nonpartisan issue. It affects everybody, regardless of your party. And in the past, it's always been seen, I've always seen it to be something where there's, it sort of transcends some of the partisanship that you see on Capitol Hill, and you see a lot of Republicans and Democrats working together. I'm not seeing that as much right now. It's just really dysfunctional, and I think there's so much concern by Republicans about spending, because we've spent a lot of money over the last 5 years, 4 years, or several years with COVID, and all of the the infrastructure and all of they're very concerned about how much we've spent. So I'm not seeing their willingness to sign on to things that they would have in the past probably signed on to, because they're so worried about the cost. So I think that's a big challenge that we have to face, and we still have to just show kind of the human impact of these things and
Mhm.
why they're really important. And I think that includes spending on like NIH, NCI, research. I think that's why they're having so much trouble getting any of the spending bills passed right now, and why there's a very good chance that come this weekend we're going to end up with a government shutdown. I mean, who knows what will happen, but I think all signals are pointing to that happening, and hopefully it won't be too long. But it does look like that's the direction they're going.
Yes, I would agree with you. If there is a bill that is going to bring people together that doesn't cost anything, you can get the Democrats, Republicans all to co-sponsor. But once there's a bit of a price tag,
Mhm.
then it seems to be politicized as to, well, we've got to cut spending. We can't afford to increase
Yeah,
spending. So it's trying to convince that saving lives and saving money in the long run is a worthwhile goal and
right.
deserves prioritization.
Yeah.
Let's talk a little bit more specifically about the survivorship bill that is one of your priorities. Can you
Mhm.
explain a little more detail how passing that bill would help reduce the burden of cancer or improve the care or the health of cancer survivors?
Yes. So it has quite a lot. It is called the Comprehensive Cancer Survivorship Act because it does have a lot in it. So some of the things that it would do, one, it does include a provision for the cancer care planning that I've talked about. So that's in a separate bill by itself, but also as a part of this bill, where it would reimburse doctors, cancer centers, for creating those care plans at diagnosis and at that transition to post-treatment survivorship. It would also, it has provisions related to creating some resources for survivorship, to help people navigate survivorship, to help with the transition to post-treatment survivorship. And it has some provisions to help people who are trying to continue working while they're going through their cancer treatment and in survivorship and having employment challenges. It has provisions related to fertility preservation in Medicaid patients, because right now that's not covered in Medicaid. So there's only certain things that can be done at the federal level or with respect to what insurance can do. So where they saw they could make a difference is with Medicaid. And so the fertility preservation there is for Medicaid patients. And it also has some funding for to create for some demonstration projects and best practices of this kinds of survivorship care, even to what you talked about, the survivorship centers. So not every cancer center has a survivorship clinic or survivorship program. And, sometimes hospitals and cancer centers have to rely on philanthropy to set that up because it's not reimbursed well enough. And so, what this would do is provide some grants to help cancer centers, especially maybe smaller cancer centers who haven't done it, to help them to build a survivorship program, because it's not always top of mind for cancer centers. They're focused on helping people, again, like you said, treat the cancer, and there's not a lot of financial incentive to have a survivorship program. I mean, you know that. And it's like, it's kind of gross to talk about it, but it's the truth. There's just, hospitals have more incentive to do things like surgeries and chemotherapy and treatment and radiation, and not so much to do survivorship care because it's really a lot of that one-on-one time sitting down with a patient. And like you said, it's not 5 minutes. It's, a longer conversation. And that's not where the money is in cancer care. So, I mean, I know it's kind of crass to talk about that, but that's unfortunately the money is how it influences the care that's delivered. And so not everybody has that incentive. And you've got to have somebody like you who's got this vision for helping people live well after their cancer treatment that want to create these survivorship clinics and survivorship centers. And not every cancer center or community hospital has that. So part of what this would do is really create some of that sort of seed funding to help them to create those, to like what you've done there. But not everybody has that. I want everybody to have the kind of care that you give your patients, and not everybody
It,
has that right now.
well, thank you for saying that. And just a case in point, it wouldn't exist if it weren't for philanthropy.
Mhm.
And I
It
wouldn't
shouldn't be that
have.
way.
It shouldn't be that way.
No.
You get so if you want an individual or an institution to do something, you provide a financial incentive, and that's what ends up getting done.
Yeah.
Fortunately, with the ability to access philanthropy, and part of that comes from being around for a long time and having been having roots in the community to be able to generate some philanthropy that allows us to provide these services to anyone, regardless of their ability to pay, because they're not reimbursed. And
Mhm.
so you just can't do it
Mhm.
through the normal mechanism of insurance reimbursement when they don't get reimbursed.
Yeah.
So you're right. It shouldn't be that way. It shouldn't have to rely on philanthropy.
Yeah.
Not every center in every community has the ability to generate enough philanthropy to
Right.
do these services that we truly know are not fluff, but are
Yes.
essential services to individuals when you look at their entire quality of life. So we're so happy that folks like you, professional advocates and lobbyists, are helping to craft legislation that eventually will do the right thing by providing some funding
Mhm.
for these important services for cancer survivors.
Yeah, that's what we hope, is that everybody should have access to the kind of care that your patients get from you and at your cancer center. So that, and we have a long way to go to get there.
Looking ahead, we've got things on the horizon like the multi-cancer screening blood test. We've got genetic testing that's probably going to become, already we're seeing each year more diagnoses lead to the need for genetic testing. And then, of course, the genomic testing, or the
Mhm.
genetic testing of the cancer cells, and all of the testing that gets done there. Those are some exciting scientific things that are going to change cancer care. They all are going to be expensive, and medications that get designed and invented are also expensive. So besides the overall cost of healthcare, what are some of the big challenges and issues you think we're going to be facing in cancer care in the next decade?
Well, I do think the cost of cancer care is a huge issue, and can, because like all of these exciting advances are not cheap. I mean, it takes a lot of research to develop these tests, to develop these treatments. And so the cost of medicines once they hit the market, and especially, the more we see how cancer is so dependent on these subtypes that have smaller populations of people. So it's not like all the treatments that come out are going to be these blockbuster treatments that can be used for many cancer patients. It might be more niche. It might be only for a smaller subset of patients, and it's really effective for them, but it's not going to have the huge market share that some treatments might have. And so then the cost is higher because it may only be, a smaller subset of patients who can benefit from it. So I think, figuring out how we're going to manage that is challenging, because what Medicare has to look at the whole program, not just at individuals, but like, how do we make sure that the program is sustainable and that we can get treatments to everybody who needs them. So I think that's going to be a huge issue. And I think there's been movement to try to pay differently for cancer care, to not, like right now we pay based on sort of the volume of care, and to look more holistically at the treatment. And actually, some of it is incentivizing doctors to try to kind of reduce the overall costs. And one of the ways they can do that is like by better managing symptoms, so people don't end up in the hospital. If you know that somebody may, that if you can make sure somebody maintains their hydration through their treatment, or that they've got a nurse on call that they can call if they've got an issue, so they don't end up going to the ER. That they're trying to sort of streamline care and better manage symptoms and side effects early, so people don't end up in the ER. It's only one, piece of the puzzle, but it's one that can be costly. And if you can bring that
Mhm.
down, because overall cancer care is really, really expensive to the system, and of course to the individuals. And then because it's so expensive to the system, that's where all these different things get, brought in, where You have to have prior authorization of drugs, or insurers try to deny things or limit care and things like that because it's so expensive. But also many of these treatments that are expensive are also very effective and help save lives.
Yeah.
So it's not, there's not an easy answer to it. But what we try to do is just make sure we're bringing the patient perspective, because a lot of times there's a lot of blame going on, pharmaceutical companies, pharmacy benefit managers, insurers, everybody's sort of at each other. And sometimes I think patients get lost in the shuffle.
Yes.
And so our
Yes.
job is to make sure we're bringing the patient perspective.
Yeah, the pharmaceutical companies, the insurance companies, even the physicians and hospitals have much bigger soapboxes and louder megaphones than individual patients. So having organizations such as yours that collectively, give cancer survivors a bigger soapbox and megaphone so their voices can be heard is really important. Shelley, if it's okay with you, I think I'd like to use the last bit of our time together to open up to questions. So we've got a live streaming audience. So I'd invite those of you that are watching us from your home to put the questions in the comments section. And we also have a live studio audience. So we've got a microphone here. So we'll start off with our live studio audience and have some questions for Shelley.
Just to start off, I was interested to hear your guest comment on the looming government shutdown. And I was wondering, when it comes to, patient advocacy, assistance, approvals, subsidization. I mean, if you're waiting to get a drug or a treatment, or you just signed up for the Affordable Care Act, or you're waiting for your Medicare approval to come through, does anybody have any sense or feeling what a government shutdown would do to that?
So what's the impact of a government shutdown on patient care?
That's a great question. Whenever there's a government shutdown, there are always services and individuals who are considered essential and still have to continue working. They may not be getting paid, but they have to continue working. Exactly what those are, I am not totally clear on all of the specific, areas that are impacted and areas that are not impacted. So that's a great question. And I'm sorry, I don't have a great answer. I do know that, I was emailing with somebody who works at the National Cancer Institute this week, and we have a call scheduled for next week. And she said, I hope that I can talk to you, but I might not be working next week. So, some of it's just, people working in jobs where it's not directly impacting patient care, and that definitely gets put on the back burner. But I think that, Medicare is still going to be providing benefits to people. Like, if you have Medicare, you're still going to be able to use your Medicare benefits to go to the doctor. But some things do get slowed down, and I don't have the sort of list of sort of what's essential and what isn't. So I'm sorry, I can't answer that better. But I do think that, there are some provisions to make sure that certain essential things still happen.
Great. Thank you. Another question?
So what are some things here in Iowa that we might be able to do to help the cause? Contact our representatives or our senators. Seems obvious, but sometimes we lose the language in the complication of things. On your website, are there contact points or things that we should make sure to comment upon if we do decide that's something we would like to do?
Yes. So if you go to our website, it's canceradvocacy.org. There's a page on the two bills. There's a page for each of them, and it talks about the bill and has a fact sheet. So you could call your member of Congress. You can just call call the Capitol switchboard and say who your member of Congress is, and they will connect you, and you can ask them to support it. And there's talking points there to help you with that. Another thing you can do is join. We have what we call our Cancer Policy and Advocacy Team, and it's our program that engages advocates in their policy work and their other advocacy work. We do webinars. Usually quarterly, we have a newsletter. We share information about what's going on Capitol Hill, where are different ways to engage as an advocate, because there's so many different ways beyond just calling your legislator. There's, research to be involved in. There's conferences you can go to. There's different So there's the Department of Defense funds cancer research, which maybe people don't know about, but they require in their review panels when they're reviewing research proposals and deciding on where the money goes, that they include cancer survivors as part of that to really weigh in from the patient perspective on how important is this research? How will this research impact patients' lives? And so you can, people who are interested in getting involved with research, we can help you make those connections to get involved in things like that. And then we also, I mentioned we have our Hill Day in June, and we bring people to Washington, D.C., and we have scholarships for that. So if you join our CPAT program, you'll find out about when our next conference in Hill Day is next summer, and you can apply for a scholarship and come to DC. And I know, Dr. Deming, you're very involved with American Cancer Society Cancer Action Network, so you can talk about that as well and how you get involved.
Yes. So another organization that does lobbying. So the American Cancer Society Cancer Action Network is the advocacy arm of the American Cancer Society. And like NCCS, once a year, we bring cancer survivors to Washington, D.C., and bring one cancer survivor from every single legislative district. And we all wear the same blue shirts. And we've got, 600 volunteers marching on Capitol Hill, some training as to how to talk to your senators and representatives, and what particular bills that we're going to be advocating for. It's a really empowering experience. The first time you go up to Capitol Hill to go meet with your senator in his office, the representative, you think, oh my gosh, I'm not worthy to be in this building. The truth is, they work for us. We're their boss. We're their constituents, and they welcome us into their offices. And you're not expected as a cancer survivor to be the scientist or the public accountant to know every single angle. You're there to show your passion, tell your story that goes with the facts and figures that the American Cancer Society provides so expertly, and the combination of facts, persuasion, and the emotion that comes from storytelling makes a huge difference. And it ends up being a positive experience for everyone who goes, and a positive experience for the members of Congress as well.
And you don't have to go to Washington, D.C. to meet with them. They usually come home every weekend, and they spend the month of August at home, and sometimes they have extended recesses where they're home for a week, and they have district offices. So I'm sure there's a district office near you for your House of Representatives, and then your senators they'll usually have several district offices around the state. So you can still meet with them or meet with their staff. And it's always just as important to meet with staff. It's not as exciting for you because you're not meeting the member of Congress, but every time you meet with their staff, they're reporting that back to their boss and telling them, who they met with, what they're asking for. They don't have to do what you say, but they do have to listen to you. And like Dr. Deming said, they work for you. And so they'll listen to you. They may not agree with you. They may not do exactly what you ask, but they will listen and often ask questions. And it's okay to say you don't know, and then ask somebody for help and getting back to them with an answer.
Those are really excellent points, because you can meet with them back here. You can, as just an individual, request a meeting. Mm-hmm. But the benefit of going with an organization like NCCS or ACS CAN that has professional staff like Shelley is you'll end up getting more bang for the buck. You'll have the professional expertise. You'll still be able to tell your personal story, and that combination of the professionalism with the honesty that comes from the street credibility of being a cancer survivor really can elevate your story and make it more effective. But anybody has the right to just request an audience with your member of Congress.
Yeah.
Are there any questions from our viewing audience?
One quick one here from Christine. She says, and this is probably for Shelley, would you see a time that policy would make it so cancer care treatments and survivorship programs would be more uniform nationwide? Christine says sometimes patients just don't know what's out there.
Yeah, that's a great question. And, it's really hard because physicians don't want Congress to legislate medical care. They get really testy about that. And so what happens is there are huge differences in, where you go for your care, may determine, the quality of care you get. And there is no uniformity. There's definitely some standards and some guidelines. ASCO, the American Society of Clinical Oncology, has guidelines. NCCN has guidelines, National Comprehensive Cancer Network. But there's no requirement that you have to follow those guidelines. Although, a lot of times the payers like Medicare and private insurers really do try to get, doctors to follow those guidelines. But when Congress talks about anything that looks like legislating the practice of medicine, the doctors really push back and say, no, and we don't want Congress. They're not there are some doctors in Congress, but they're mostly not doctors, and we don't want them legislating it. But unfortunately, the side effect of that is, or the result of that is, then we have this sort of variance in care. And there are places where you get really good care, and there are some places where you don't. There's like efforts to share hospital ratings that would try to help give consumers information about the quality of care you might get in a hospital. But it doesn't necessarily tell you the quality of your cancer care, there's definitely some controversy over the hospital rating system, and hospitals don't like to be rated unless they're really good. And then they want to tell everybody about their good ratings. But I think that I don't see us moving towards more standardization of care. What do you think, Dr. Deming?
Well, I agree with what you said, but things have changed. So I graduated from medical school 42 years ago, and it used to be when there was a paper or there was a new standard that came out, it was disseminated by paper. You had to go to a library. You had to look things up. It took over 15 years from a change in a standard before it was actualized in the community. Now, I would tell you that with national guidelines that get changed, instantaneously, and where we go to those guidelines online, that we have in my cancer center 12 multidisciplinary cancer conferences a month that adhere to the NCCN guidelines, and that across the United States it is adapting and adopting the new guidelines happens much more quickly now than it did 40 years ago because of the instantaneous nature in which things are disseminated. I can't remember the last time I went to a medical library, looked up something in an old-fashioned, file to pull and Xerox a copy of an article. So I do think we are making progress, and fortunately, those organizations, ASCO and NCCN and others, are including survivorship guidelines. So I see some light at the end of the tunnel, and some work that is going to speed up the adoption of guidelines across the country. One of the things we didn't get a chance to talk about is that cancer affects everyone, but it doesn't affect everyone equally. And we have many vulnerable populations that doesn't matter what the guidelines are, if they're not in an area where they get the access to care, that's a huge discrepancy. But Shelley, we're going to have to leave that for another conversation.
Okay, that sounds great. And I'll just say this, we do talk about that in our survey. We know differences in the impact of cancer among different populations based on their access to care and the other barriers that they're facing. And so tune in next week and you can hear more.
Well, Shelley Fuld Nasso, CEO of the National Coalition for Cancer Survivorship, thank you for being our guest. And for those of you who are watching, if you know someone that would benefit by watching this program, please go to the Above and Beyond Cancer YouTube channel or the Mercy One Cancer Center website, and it's available on demand beginning tomorrow. I hope you'll join us again next week. Thanks, everyone.